Hello and welcome to the American Society of Regional Anesthesia and Pain podcast, ASRA RAPP. I'm your host, Raj Gupta, coming to you from Vanderbilt University in Nashville, Tennessee. And we have a fantastic topic today. We're going to be talking to two experts on the management of cancer pain and supportive care around cancer pain. This is a big topic. Obviously, we're not going to cover all of it today, but we really want to introduce you to some important concepts for both providers and patients. And I think this is going to be a really interesting conversation. Before we get to that, I do want to mention a few things about upcoming events with the American Society of Regional Anesthesia and Pain Medicine. We have several important events coming up. The fall meeting is coming up November 10th through the 11th in New Orleans. It's at the New Orleans Marriott, and it is chock full of information. And we do want to mention a panel that's going to be on cancer supportive care at the meeting. And so make sure you check that out in the program as well. We'll bring that up again here in just a few minutes because I think it's important for people to show up for that. This meeting is going to be open for abstracts and then obviously registration very soon. So make sure you go to the ASRA.com website and check out all the important dates. Always remember there's lots of upcoming events for the society. There are point of care ultrasound workshops, ultrasound guided regional anesthesia cadaver courses, obviously our annual meeting. There's webinars. Some are free, some are paid for, some have CME, some don't. But it's really important to look at this page of all the future upcoming events and keep up with all the opportunities. We want to make sure that we can entertain those people who can attend in person, those who can't, some who are abroad, some who are local, all of those. We want to include everybody in those opportunities. So make sure you check out the page. Lots of great content available for you there. I do want to mention that this specific topic that we're going to be talking today is sponsored by the Cancer Pain and Supportive Care Special Interest Group. So if you're interested in these topics, we encourage you as a member of ASRA Pain Medicine Society to join this special interest group. And you can go to asra.com/SIGS/cancer. So I'm going to put this up on the screen. It's asra.com/SIGS/cancer. And this is a great place to go find more information. And those two faces that you see up there, I'm going to bring them on the screen right now and do my introductions for them. Well, I want to do some introductions so people know who you guys are. Bear with me as I list your many accomplishments and be humbled by all of that as I speak about you. So first we have Dr. Amitabh Gulati. He's an anesthesiologist and pain medicine physician currently practicing in New York City. He's an associate professor and director of chronic pain, specializing in interventional cancer pain management at Memorial Sloan Kettering Cancer Center. He's currently the program director of the Weill Cornell Pain Management Fellowship in New York City. He regularly gives lectures and teaches at workshops on topics involving ultrasound-guided pain procedures, interventional procedures in cancer pain management, and neuromodulation techniques for oncological pain. He's also the chair of the Cancer and Supportive Care Special Interest Group. Welcome, Mamit. How are you doing?
I'm doing well. Thank you for having us talk on this wonderful topic and very important, near and dear to all of our hearts.
Excellent. And I want to introduce our second guest, Dr. Vasudha Goel. She's an associate professor with the Department of Anesthesiology and Pain Medicine at the University of Minnesota. She found her interest in pain management while completing medical school in India. As an interventional pain management specialist, she is the site director for the Pain Medicine Fellowship and directs the cancer pain practice at the University of Minnesota. She has interest in health services research and improving outcomes for cancer survivors. After clinical duties, teaching, and clinical research, which is plenty, she enjoys painting and spending time with her two little kids as well. Welcome, Vasudha. How are you?
Thank you for the very generous introduction, Raj.
These are all your accomplishments. I'm just reading the words out loud. So you guys get all the credit for that. So this is an important topic, and I want to kind of jump right into it so we have plenty of time because we're going to cover a lot of content and material today. And I'm going to start with you, Vasudha, that we mentioned the fellowships, and I know both of you guys are involved in training fellows. We're starting a new fellowship season very quickly. And I want both of you guys, and I'll take you, Vasudha, first, and then Amit as well, Talk to me a little bit about what the fellows should be looking into as they're entering their fellowship year and thinking about, and then how they we'll talk about how they expand into their practice after that.
That's a very important question, and thank you for asking that. The fellows should uh, keep in mind what brought them to medicine and why they're pursuing the specialty. And I think to the heart of that would be they want to serve our patients, including our cancer survivors. So they should be looking at fellowships that give them the breadth of experience and both clinically, research wise, and in teaching to go ahead and serve our chronic pain population no matter where they take a job after training.
And Amit, how do you what are the things that people struggle with when they're in fellowship? Is they're so focused on learning about the content, but often we're not thinking about how to build and develop and advance a practice. What are things that they can learn during fellowship to be prepared to deal with a complex world of practice management these days?
That's a great question and very insightful. We're definitely focused clinically on how to take care of our patients to the best of our abilities. One of the hardest things is to understand how to make that successful transition to a practice that can do that for the community, regardless if it's a hospital-based, academic-based, or private practice. I think when you look at the different practices you're going to be working with as a fellow, you really want to get involved with the aspects of billing, how you clinically make decisions, but also how you authorize these procedures, be a part of that team. I think that's very important. So instead of just focusing on the procedure itself, maybe discuss with your attending, your mentors, how did you get that approved with your insurance? How is that coded? How is that billed? How do you know you got reimbursed? Um, and probably the most important thing I tell of our current fellows and our future fellows really is work with your staff, see how the staff interacts with the patients, the process of getting a patient checked in to your clinic, discharged from your clinic. See how the staff is part of the logistics of all of this. I think that's very important, because those are the people you're going to be hiring. Those are the people you're going to be involving in your practice to make it successful. So we want to be part of that process and working with the staff, nursing, MAs, et cetera. How do you optimize this? How do you bill? Something you can do with your attendings. And honestly, some of these things like at ASRA, some of these conferences allow access for fellows to talk with other attendees and other practices. And you may have these questions already lined up. How do you make a successful practice in Arizona versus New York? What are some of the factors in Phoenix versus a smaller city? I'm, Cortland, New York, for example. So how you make some of these ideas may be different, and ASRA and some other organizations may allow you to have access to some of these physicians that you may not have access to during your fellowship.
Uh, that's very well explained, Namit. I would like to explain our viewers with an example. Lumbar declopathy is a very common diagnosis we all see in our clinics. Our trainees are doing extra training to kind of become specialists in this area of pain management. And recently, I saw two patients back to back, same lumbar radiculopathy, medically same diagnosis, but very different cases because of different levels of education, different socioeconomic background, different insurance coverage, different resources they had access to. And I think training programs help make you into a better specialist to deal with these challenges that are bundled with every person that comes. The medical diagnosis may be the same. And I think expanding their network with the physicians they're working with during training and after, when looking for jobs, looking at these opportunities for self growth, locally in their practice, and then nationally with societies like American Society of Regional Anesthesia and Pain Medicine, provide.
Yeah, both of you guys mentioned a really important thing, which is that network effect. We have to educate and learn from each other. One of the things that the society is doing is to create both formal and informal mentorship programs. So we have a formal mentorship program for those people who are seeking mentors. You can actually apply for a certain type of mentor, and you'll be connected with people that might be in academics, in private practice, in a different region. And that can be a great resource just by themselves, but also to expand your relationships through that person to the people they know in other locations and with other skill sets. But informally as well. I mean, I can't tell you how much I've learned just from meeting people in the hallways, or coming to a SIG meeting, or sitting down with somebody at a lunch or something like that. And we often get to talking about our challenges. And sure enough, everybody has the same challenges in some form, fashion, or another, or everybody has had them at some point and dealt with them in different ways. And so that resource of that community is extremely powerful. It's one of the reasons I love going to in-person meetings, is for those spontaneous conversations that are often not represented by the lectures. The other thing is that in the pain management fall meeting, we have a practice management component of that curriculum, and it's really well attended. Really, really well attended. There's a lot of people that show up to those sessions because it is such a vital component of chronic pain these days. So I encourage the fellows to come to the meeting, meet people, become part of that network, and have those resources available to you, but then also attend the sessions where you can actually get some formal learning about that as well.
That's really true. I also want to highlight a couple of other things that's coming up in the ASRA fall meeting this year. Networking is important. I would love to see you all and kind of, expand on more chronic pain management and cancer pain management interest of yours. But I would like to highlight we do have a dedicated panel on chronic cancer pain management at the ASRA Fall meeting that's happening in New Orleans on November 10 and 11. We also have a number of workshops which can be used in this population and other chronic pain populations. Um, this topic is not just for fellows pursuing chronic pain management. The burden of chronic pain and cancer pain is huge. It's much bigger than just pain physicians can tackle. So, everybody at the meeting, anesthesiologists, acute pain management physicians, neurologists, PM&R physicians, anybody who should be there, it is relevant because at some time you may come across patients who are cancer survivors who can benefit from your expertise and this exposure to knowledge you have regarding cancer pain management.
We also have a growing contingent of advanced practice nurses that attend these meetings, that are obviously very actively involved in a variety of pain management situations, both in acute and chronic pain. And so I encourage those people to pay attention to these same topics because it's relevant for them. So I want to jump into the topic a little bit more. So we have this article. I'll throw it up here. I'll make it a little bit bigger here so you can see. Barriers to Pain Assessment and Management in Cancer Survivorship. This was published in the Journal of Cancer Survivors. This is a survey based and sort of case presentation based scenario, talking about various barriers that are present for patients, present for providers, and present for systems, and how those can be made obvious so that we can actually attack the problem. I mentioned this article. It's a good read. It's not. It brings up more questions than it obviously does answers, but I think that it's an important start of the conversation. Amit, you want to talk about this a little bit, about the barriers you guys see and some of the ways you're dealing with that?
Yeah, it's I think to come step back and it's maybe sometimes hard to be a patient in this kind of situation, but step back and think about what a cancer patient is usually going through, and pain is usually a secondary problem. The primary problem is living, surviving, being with your family. After you have your diagnosis of cancer, can you cure it? Um, and the pain maybe you're a side effect of the treatment itself or the cancer, but most of the people who are going through the cancer are really more worried about taking care of the cancer. And therefore, the practitioners taking care of them are focused on taking care of the cancer as well. One of the examples I always have, we have a lot of patients who suffer from pain after some form of breast surgery after the diagnosis of breast cancer. But if you talk to the patients that have breast cancer, their primary focus is to get rid of the cancer, and they might even discuss their pain with their oncologist. may not come up, and then maybe some of the patients I've talked to over the years, they may cope with the pain saying this is a side effect of my treatment, but I'm alive. And so as a result of they might even bring up their pain with their oncologist. So the oncologist is focused on the cancer. Your cancer is being controlled with replacement therapies. The pain may not be a discussion point. It may be discussed with the advanced practice provider and not the actual oncologist, and therefore the treatments that are available for pain may not come up immediately. We'd like to treat patients the day before surgery to have them ready to help and get them through pain after surgery, and then through radiation and through other some of the things they're going to go through the journey of pain. When we see patients earlier on, and most of the patients are women, they're very surprised that a service exists to treat their pain. They didn't know something could be done for their pain many times, and they didn't know that treatments could actually help their pain if they're survivors of the cancer. So, really, our tact has become not only to try not only target the oncologist to say, look, we can help you with your pain. You almost have to go to the consumer here. For breast cancer, for example, in October, breast cancer awareness walks and runs, different events come up. You almost have to, at the same time, advertise that a pain service can help you manage your pain. And you'll see that patient will come out saying, I have pain. I didn't realize there were options available. And so those are some of the barriers you have to overcome. It's really that it's a secondary problem to the primary issue of survival, as opposed to perhaps a chronic pain where that's the primary problem. And so patients may not be aware of treatments because they're really worried about treating the cancer, surviving the cancer, and the pain may be a consequence of it that we can cope with.
Yeah, the term in the article they use is fatalism about their pain control. And
I don't like that word.
yeah, it's a really harsh word,
Yeah.
especially when you're talking about cancer. But I see what you're saying, that like, this is the burden to bear, to get better from the cancer. It's I can see that happening. I think I've seen that in family members, where they don't even want to mention how much suffering they're in because they're grateful for their treatment, and they feel like they don't even know that there's other options out there. Vasudha, you want to talk about this a little bit too? I mean, what other barriers have you encountered with your patients that you see them, or in the community where you're like, come see us. We have opportunities. We have solutions for you.
Mhm. So the barriers are multifold. Like Amit highlighted, people don't know that there are options for symptom management. Oftentimes, the symptom of pain may have led to a diagnosis of cancer. There is literature pointing us in the direction that our patients feel that pain is a part of the disease, and they cannot go through treatments without the experience of pain. I want to mention to our listeners that there are many options of pain treatment. We may not be able to help every case, but it's a little heartbreaking when I see patients and they haven't talked about their symptoms sometimes for years because they just didn't know that there are options, and the treatment of pain can go hand in hand with the treatment of the primary disease, which is often cancer in this population. So I want to say it again, treatment of pain like symptoms and other symptoms of cancer that led to the diagnosis are because of the treatment of cancer have management options while our patients are getting treatment for cancer. Some of our patients may have pain syndromes because of other aging, arthritis type of pain, and we treat that in our general pain clinic all the time. So there are lots of options for treatment of pain. Um, so there are barriers at the level of the patient because they don't know, they're fearful about talking about their symptoms. They don't want to distract their physician or clinician or advanced practice provider taking care of them from life saving therapies. Um, they don't want to come across as rude. But then there are also barriers at the level of providers. We tend to work in large systems. We may not know of resources that are available in the system across the street or within our institution or within the same city. So, networking and making communities and hearing from what physicians in other parts of the country are doing is what ASRA does best to bring people together so we can take better care of our patients. And then there are system level barriers that uh, need to be slowly studied and addressed in a systematic way because there have been studies showing some disparities. We know, disparities can be based on gender, socioeconomic status, and other factors. The socioeconomic disparities often talked about. Um, so why, a patient being seen in the pain clinic is kind of a tip of the iceberg. Why do some patients make it to the pain clinic referral and why don't some make it through that referral process is unclear. I think at a personal level, we have to be very conscious of our own biases and treat everybody appropriately and communicate with our peers and referral sources and try to address them and take steps, whatever is within our means, to reduce that as far as possible. And then we will overall see improvement in our communities as a whole.
Yeah, Amit, you talked a little bit about how to overcome some of these by reaching out to the patients, going directly to, as you said, the consumers, and making sure they're aware of their options. What is it that you think needs to be done in the system itself as far as building relationships internally? And what I mean internally is within colleagues, within hospitals, within community physicians to make these opportunities more evident. How do we reach out to them?
This is a great question. I trained many fellows over the years, and a lot of our fellows want to treat cancer patients, try to achieve that within their practices and find roadblocks. And really, the key to identify those roadblocks and see what can you do to overcome them. When it comes to your own practice, I think taking care of cancer patients is a little bit more. You have to have a little more dedication with time allotment. You have to be more flexible and seeing patients later during the day, weekends sometimes if they get admitted to a community hospital. So your practice has to be amenable to managing a more complex pain issue. So that's the first step. Get your practice ready to take care of intrathecal pumps if that's what you're going to do for cancer patients. And consultations have to be maybe more flexible when they occur and those kind of things. Once you have your practice kind of ready, um, a lot of us will try to go to an oncologist and say we can place an intrathecal pump, for example, if your patient's pain is out of control. But again, you think about what the oncologist and what the APP is taking care of patients, what their needs are. For the oncologist, for the staff that takes care of a cancer patient, they're not trying to get a block. They're trying to get pain managed. That means taking care of the patient from start to finish, including pharmacotherapy and blocks together. So if you can help manage the actual opioids, the other medication involved with the cancer patient's pain care, then you're more likely to get an oncologist to buy into what you provide as a pain service. So we don't talk about pumps per se. We talk about holistically managing a patient's pain if the patient's pain is out of control with initial opioid management strategies as a starting point to consult our service. Same thing in community. An oncologist needs your help managing pain, not necessarily needing a celiac plexus block only. Um, the last thing probably is most useful, and there's many points obviously, but perhaps what's most useful is there's a number of different specialties that manage pain in oncology. Bone metastases, an oncologist may send to a radiation oncologist first before they even think about a pain physician. They may say a tumor is growing too fast or too large. They may go to a surgeon to manage to manage the palliative pain and those kind of things and do a surgical option. So there's a lot of different sensory services that support oncology that manage pain, and really you need to work with them. You need to work with a radiation oncologist, and can you provide a structure of pain relief to a patient suffering from pain during radiation? And if they don't successfully improve with radiation, same thing with surgery. Work with your surgeons that are doing oncologic surgeries and support them perioperatively for their pain, but then if postoperatively the pain lingers, then you're there to treat them afterwards. A lot of the times, supporting the other physicians that manage oncologic pain will make your practice grow quicker. The biggest thing is to have your practice ready for the type of pain patient you want to see in the community. I think more likely where you're going to see breast cancer is very more common, mastectomies are common, so therefore post-mastectomy pain syndrome will be more common in the community. Clearly there's other strategies, but I'll let Vasudha and you kind of chime in and make it as more of a conversation.
Yeah, it's interesting that you I ran our acute pain service for many years at Vanderbilt, and when I took it over, we had a lot of the same biases with our consulting physicians about, oh, you guys are only interested in doing this injection, but you don't really care about what happens to the patient. You know, they had the pejorative block jock kind of terminology for us. And then once we expanded to say, no, we're going to be perioperative acute pain physicians, perioperative physicians, and help you throughout the process, all of a sudden our consultations and in engagement from our surgical colleagues, increased trauma colleagues, everybody was interested in what we had to offer because we weren't a one-stop solution. We were offering consultation about overall pain management and not just, I'm interested in doing this sort of glamorous part, but not necessarily all the hard work. And we're going to dump all the hard work back on you. That was not the solution. We wanted to be partners in that process, both the good and the bad. And again, we ended up with more business than we could handle faster than we could imagined, you know.
That's a problem you want.
Yeah. Well, but
There,
like you said, your group has to be ready for that
Yes.
because
Mhm.
you make a promise and then you may not be able to execute on that if you're not prepared for it.
Yeah, you want to be tailor focus, sorry, on your what your group can achieve first prior to deciding how to market your skills to other physicians. So go ahead, Vasudha, sorry.
No, this is perfect because I was gonna say resources at every place can be different. They can have a different flavor to them. Amit and I both have cancer pain services. He's in New York. I'm here in Minnesota, and I'm sure we have very different structures and resources. So I think the first step is to really understanding the population you're catering to. What are the resources at the institution you're working to? What are their strengths and weaknesses? And kind of focusing within your practice to complement that, and then start identifying patients that you can possibly help improve their outcomes, and help the community as a whole. Pain management is a big spectrum. So here we're kind of tossing between the idea of acute pain and chronic pain back and forth. But Amit and I probably do a lot more chronic pain, and Raji are more in the acute pain realm. But in the chronic pain, cancer pain management treatments have a whole spectrum. There can be self management, non pharmacological, complementary medical treatments such as acupuncture, massage, mindfulness. And then the pharmacological treatments can be as simple as, NSAID class of medications, Tylenol, moving on to muscle relaxants or neuropathic medications if a patient has a neuropathic dominant pain syndrome, and then possibly opioid medications when appropriately indicated. Interventional pain management kind of fits into the spectrum for select patients who may benefit from a nerve block or neurolysis or implantable pain control, um, that is not for pain syndromes that are not managed despite following that whole spectrum of pain care.
Well, let's bring up one of the interventional techniques. And I have an article here that you guys shared with me that brings up the intrathecal drug delivery systems. And I think it's written by a couple of people you guys know. I see our two hosts as co-authors on this paper. This is intrathecal drug delivery systems for cancer pain control, insights on current contemporary practices in the United States. And this was published this year in Neuromodulation. And I want to jump ahead because this is, you guys were trying to assess how many people were getting intrathecal drug delivery systems as part of their management. And I want to go down to this graph here. Um, Tell me a little bit about what you see on this and what this tells you about the use of intrathecal drug delivery systems. Um, Vasudha, why don't you start with this?
Sure. So Amit and I worked together on this paper, and I'm going to take a step back to give our audience a little bit of background on how the cohort was developed. So this paper was is coming out next month. It will be in print next month. So we looked at the national inpatient sample, which is sampling of patients across the US. And we looked at patients admitted to hospitals for cancer pain and divided into patients who were receiving the intrathecal drug delivery system for cancer pain and patients who did not receive it, and kind of looked at trends. Um, so what this graph here is showing is the top 5 subtypes of cancer who received intrathecal drug delivery therapy in the US from 2016 to 2019. So lung and bronchus was top. The second number was colorectal. Third was ovary, and then bone and liver. But there's another graph, probably on the first page, which kind of shows the top 5 cancer uh, related hospitalizations in 2017, that, or yellow one.
The yellow one. Okay.
Um, this one. So if you look at it, the top 5 were secondary malignancies, colorectal, then lung and bronchus, prostate, and kidney. So a little bit differences there, but if you take a deeper dive into the table that will be coming out in print, um, less than 0.5% people received intrathecal drug delivery system therapy across the US. It was only 0.3%. Um, it was about 3 to 4% patients with cancer-related pain who got palliative care consultations. Most of the patients who received intrathecal drug delivery system therapy were at urban hospitals, tertiary care centers, academic centers, were Caucasians, and tended to be of a higher socioeconomic class in this study. So this is just taking one treatment, and it shows that there are disparities in delivery of cancer pain treatments. And this particular paper highlights just one interventional pain treatment because we are interventional pain physicians. We looked at it, but there's other papers in literature that also highlight disparities in cancer pain care delivery.
Yeah, what strikes me and is the scale of the numbers. So if you just take lung and bronchus at 122,000 cancer-related hospitalizations in 2017, and then you go through and you look at lung and bronchus, 6,215 received intrathecal drug delivery systems, but this is over a 3-year span, 2016 to 2019, 3 to 4 year span. That is a massive scale of lost care of patients who have not received. And I'm not saying that intrathecal drug delivery system is appropriate for every patient, but what I'm saying is I don't think it's that small of a scale. I think that basically this wasn't an opportunity for these patients to receive advanced levels of cancer management. Amit, do you have any comments on that as well?
You have a lot. Like I think we have to take a step back and look at what's happening in trending in oncology. Um, I'm not doing that many intercostal neurolyses anymore for lung cancer patients. Immunotherapy has changed the trajectory of some of these lung cancers significantly. Um, Oncology is doing a much better job controlling their disease states, and therefore our pain therapies are adapting to it. When I truly wholeheartedly believe still intrathecal drug delivery systems are very useful. But if you ask me if I wanted a pump implanted, I would try to avoid it. And I don't really want to have surgery. They're going through so much surgery as it is. And really, what we're trying to do as a cancer pain medicine practice is think of strategies so that we don't have to necessarily do surgical implantations. And all of our algorithms in our hospital system are based on that. There are a lot of different things that we do before we get to intrathecal pumps. Um, and there's a lot of different ways to control these disease states. So I think what you're seeing with intrathecal drug delivery is that you're seeing access based on socioeconomic state and what's achievable through a commercial insurance and Medicare, and centers that can actually support an intrathecal drug delivery practice, and that's difficult in itself. That's why we see pockets of these things happening. But you have to look at other strategies that are helping patients with their pain. And I think what's happened, at least since my career started in 2006-7, is that we have a lot of more different options for pain control, so we don't have to get to an implantable system. that's permanent in nature. And I think we're seeing those algorithms come in play. And as that information percolates, we're helping now a chronic pain syndrome for many of these patients, and trying to avoid some of these complex devices, because quite frankly, people don't necessarily always want to have these implants. They're still thinking of an implant as a last resort, even though we know that perhaps an intrathecal pump maybe have been more helpful a year prior. Most people don't want to go to another surgery and those kind of things. And I think those are some of the barriers. Clearly, accessibility that Vasudha's data really showed is critical to having patients have the option of having intrathecal pump. But we have to remember we're in a country that can afford an intrathecal pump. You go to most of the world, they're looking at different strategies to manage pain because an intrathecal pump may not be economically feasible in their environment. And there are lots of different things that other physicians do across the world to support our cancer patients that may also be helpful. And we have to remember those techniques that are available, neurolyses and other things that were helpful for many patients around the world, that intrathecal pump may have replaced. But when economics come on board, you may want to remember some of the things we have done, are doing in other parts of the world, and then we may have done in the United States before intrathecal pumps became prevalent.
Yeah, it brings up an interesting conversation that probably is beyond the scope of our talk today, which is when we're talking about being that proper consultant for a patient's overall experience, as you mentioned earlier, sometimes uh, things that are appropriate for the patient care may be uh, detrimental to our practice's bottom line, and can often make people reluctant, whether consciously or subconsciously, to move to a protocol or an algorithm that actually hurts their business, and makes it difficult to maintain that whole practice that's necessary to provide all that care. It's a weird conundrum to be in. That often I say, again, I'm using my own examples in the acute pain world, is if there's a solution that makes it not necessary for me to do this XYZ intervention, then I need to support that if that's the right solution for the patient, even though it may be harmful for us. And we need to evolve to match the growing science or the growing technology or the evolution of data. If we don't, we're just stuck in our old ways, and that's going to be harmful for the patients overall. And that's a hard conversation to have sometimes.
No,
Yeah,
clearly,
I think
clearly resource allocation is very important. Sorry, I'll be very brief. I think when you come to practice management for intrathecal pumps, the logistics of managing from pumps is vast. It's easier to do an injection in an ASC than to have an implanted device and manage it long term. There definitely are resources, pharmacies, implantation devices, companies that are helping you with the logistics to make it successful. But really, these things have to be planned out, and you can see that. You can see that in other countries where it may be difficult to have the logistics, and therefore they take a different tact for the treatment for the same type of pain problem.
no, it's perfect. I mean, these are important points to keep in mind. We cannot develop our practice thinking, oh, I'm going to offer just blocks or a pump implant type of services. We really have to have a very deep understanding of the resources around us, the population we're serving, and the strengths and weaknesses of the system we're with when developing these programs. Um, Keeping those in mind, we also have to have a deeper understanding, what do our patients and communities want, and how to bridge that gap, right? So first of all, it's knowledge and education, but once they know, okay, there are all these options which can look very overwhelming, what do these patients and their family members and what do our communities want? And how can we bridge that gap between what they need, what they want, and what our systems can provide for them?
So I want to spend a couple minutes at the end of this, and we're running long a little bit, so we'll kind of keep it brief, and talk about the patient side and their families and what they're going through, and where they can get more information. And you guys passed on to me this brochure from CancerNet, which is a resource for patients, both informational and It has a lot of other resources built in, including some apps to help with tracking pain, some network of networks to learn from, and people to reach out to. Um, how do you advise patients navigate this process of both the pain during treatment and the persistent pain that might occur after treatment? Vasudha, you want to talk about that a little bit, and then I'll jump to Amit about this. Um, this is a great starting point for people, but what advice do you want to give to patients?
So, first of all, please be open with your healthcare providers about what your symptoms you're experiencing, and be prepared. This website on cancer.net, prepared by the American Society of Cancer Oncology. Um, I think I said their name incorrect. American Society of Oncology,
Clinical oncology.
Clinical Oncology provides
Yes.
resources on how to track or diaries on how to track your pain picture and what medications you're consuming, and be open to having those conversations with your provider and what resources you may have around them. This booklet actually goes over options for patients to make them comfortable to talk about their symptoms with their providers. And this is just one resource out of many that is available online. There are many podcasts available online to talk about cancer pain, but be open to understand what options you have and what trajectory your pain may have as you undergo treatments.
Amit, do you want to talk a little bit about patient suggestions?
I'm not a patient of cancer, but I know how hard it is to get a doctor on a phone call. So
Yeah.
I think the key is um, twofold. One is, as a cancer pain physician, really be out there in the community, promoting that these options exist. So we're advocating for the patient. For the patient, um, if this is going to be a patient video, I think patients do this already for their care. They're already online looking for things. They're already on blogs in oncology looking, like my lung cancer patients will be on lung cancer blogs and those kind of things. There's a lot of things online that most patients are seeking out care. So our job is to have information that's available. You might have to become like a Google expert and become first line on a search engine so that patients can find these kind of things. But you almost have to put yourself, where would a patient go um, if they're in pain and have a certain cancer type? And a lot of our patients will go to community blogs, communities that have cancer, something that's a population that is similar to they are. And Memorial Sloan Kettering has different events for patients suffering from a similar type problem. So we almost have to have the information available and accessible, and then the patients have to advocate. And all this, unfortunately, comes down to marketing from both sides. We have to have marketing strategies to take care of patients who are having pain so they can access the information and access the physicians that can help them, but they're not going to find it themselves. They're going to look for things, and you have to have your information readily available. So if this cancer net is available online, it has to be first on the search engine for ASCO when someone types in cancer pain, and that's what's going to help a patient. So when they advocate for themselves, they find something like this. I haven't found that when I type in cancer pain. And actually, probably should look today on Bing and on Google and on Safari and figure out what Siri says on cancer pain, and see if what they find. The strategy from us would be to, whatever we think is most important, put that on the first, and so that patients can have access to pain physicians that would help them. We have to think of it together. They're really just not linked independently of each other. We have to think about what a patient would do if they're in pain trouble. And most people probably search or ask their oncologist or ask their friends what they do for pain. So we had to target each one of those groups that someone would ask, and we need to be available. The information has to be projected as early as possible in the search. It's like almost like AI or Chat GPT or something had to figure out how to access the information first. We had to provide that as a provider in that milieu, and then the patients have to advocate for themselves and find that information.
The literature is very clear that there are about a third of cancer survivors who have chronic pain, and many of them it's not fully treated. The literature is very clear that patients who advocate for themselves and ask for symptom control are the ones who are likely to get some treatments for symptom control. So, from this podcast, I would really like our viewers to advocate for themselves, be open, talk about your symptoms, ask for options. It is okay to treat your symptoms while you're getting definitive therapies.
And bridge that into what downstream may require, and maybe it's less because you started earlier. I think the biggest fear that I've heard from people is, if I start this, I'll always be on these medications. I'll always be reliant, and that I want to tough it through, or I want to avoid that. And actually, there may be 10 times more options for you that are not opioids, that just having a conversation with a pain physician might open the doors to. And I think it does take advocacy from the patient and the family. Sometimes the patient won't advocate for themselves. I have a few people in my family that are quiet sufferers, but as a family member, we can advocate for them and push the system to recognize that there's still need there, beyond the cancer, and that we should tap into resources that are available to us. But as you've said, both of you have said, patient advocacy, both from the clinician side and from the patient and the family side, is going to be important to make this possible. And so I encourage physicians, physiatrists, physical therapists, advanced practice nurses, anybody involved in this, to be on public platforms so that good information gets out there and overrides bad information. I think that's the best way to saturate the system, is to make sure good information is on the internet, in publications, in reading materials, in clinic lobbies, wherever patients are getting their information. We should be saturating that with good information and not leaving it up to people who are sharing bad information, because it's hard for patients to know the difference.
That's a very good point. Just because you advocate, you're not sure who is actually going to give you the appropriate treatments. You see this in chronic pain medicine all the time. There's a lot of different types of people that are actually treating pain, not just a interventional pain physician. And so there's a lot of different opportunities for patients to get care. Knowing what's the correct care is the harder part. Also, in our field, um, access to different things will give you different kinds levels of care, but also there's no consistency in some of the things that we provide. There's not as many randomized controlled trials for our field as there are for some other fields. So a lot of this is based on experience, um, and there are inherent biases that can tailor what decisions a physician is going to make, and then patients are going to get certain kinds of care that may or may not be the appropriate care. But again, we may not know what's appropriate either. It's still a fledgling field that we're developing as a group with Vasudha and many other colleagues around the country and the world.
And sometimes appropriate care may depend on the system and the place you're getting care and what the protocols are and what the resources available are. Um, the point of our talk is that there are options. Not all pain treatments are addictive. It's okay to talk about what you're experiencing, to have a better quality of life, to be there for your family members and friends so you can do the things you like to do and be a productive member in your communities.
Well, I want to thank both of you. This was a fantastic conversation. This is a world I don't live in. For my practice, I don't live in the cancer chronic pain world. But of course, we see these patients come to us in the operating rooms. We see them in the hospital on the acute pain service. And more importantly to me, I see it in my families. These are family members, friends that are going through this, and I want to know what options there are for them, and I want to be able to advocate for them as well. So, and hopefully not for myself in the near future, but that might come up someday as well. So, I really want to thank you guys. This is an excellent conversation. If you're interested in more, as a clinician, if you're interested in more of what both Amit and Vasudha are working on, and many other great physicians like them, go to asra.com/SIGS/cancer. And it's a great way to contact a group of like-minded people working in this field, and hopefully being able to contribute to that. this is going to affect all of us in some way. So I think it's important for us to be educated on it and to educate our colleagues and friends on it. So thank you again. I hope you have a wonderful day, and I hope everybody can join us at the fall meeting in New Orleans. And if you do, come say hi to all of us. We love to talk to people. We love to meet them in person. So we'll see you soon. Thank you.
Thank you, Raj. Thank you, Vasudha. That was great.
Bye-bye.